I'm Kerry, and I'm going to be doing my capstone project on strategies to prevent alarm fatigue in telemetry units. If anybody works on a telemetry unit or IC unit, you hear constant alarms and noise, the beep, beep, beeps. So we're going to talk about strategies to prevent some of the excess noise. So what is alarm fatigue? Well, it occurs when clinical staff are exposed to excessive number of alarms. What happens is desensitization occurs with these alarms, and staff will overtly not respond to them in a timely manner just because they hear them so often. And sometimes alarms are missed. Not only that, stress is commonly accessed on the unit, and this affects patient safety. Bedside alarms are used on every patient nowadays. And nurses hear alarms all day, and it's chaotic. An analysis was done on Johns Hopkins University Hospital, and it revealed during a 12-hour shift, over 59,000 conditions or events can trigger alarms, or that can lead to 350 on average alarms per patient per day. That's a lot of alarms. Let's talk about a real situation that happened. In 2010, a 60-year-old patient was admitted to an ICU in Boston, and the nurses turned the bedside alarm down. She was busy with her other patients. Apparently the critical alarm started to go off at the nurse's station. Everybody was busy, as that often happens. This went on for an hour. By that time, the patient had suffered an anoxic brain injury and ultimately died. Scary stuff, but unfortunately this is not the only time something like this has happened. Since 2005, over 200 patients have died, and it's been directly linked to alarm fatigue. The Joint Commission released a Sentinel event report identifying alarm fatigue as the cause of death in 80 events from 2009 and 2012, and there were more events that led to serious injury. It's estimated that 24 patients die each year from this. Why is this? Well, one reason is there was a study done in 1983 done by Kerry that showed when more than 6 alarms are going off at once, it causes the caregiver to be confused as to what alarm it is. And it does really actually, it's contrary to the patient's care. Another study was done to examine whether or not nurses, physicians, respiratory therapists could actually even identify which alarms were, if they could differentiate which alarms were heard in an ICU. And out of the 33 alarms they examined, they could only correctly identify 50% of the critical ones. And those are the alarms that are louder or have a specific rhythm. And they only could correctly identify 40% of the non-critical. So, this is obviously a problem for patient safety. So we talked about the confusion when more than 6 alarms are going off. The chaos that's going on these units, you guys work on them. We have the IV pumps that are beeping. bed fall alarms, SCD pump machines, ventilators, feeding pumps, wound vacs, the cardiac monitors. Everything has an alarm now. And, since 1999, more than 40 different alarms are often used in ICU and telemetry units. So what do we do? Medical alarms, we need them. They enhance patient safety. They are the standard care and practice. They notify us when our patients are deteriorating, and they also notify us when the device is malfunctioning. The reliability, that's another issue. The thresholds are set for high specificity and for high sensitivity but low specificity. What that means is the ideal system would be that it would never miss a clinical significant event, and it would be 100% specific, meaning that it would never go off unless a clinical event occurs. Well, we haven't gotten there yet with our alarms. So most alarms, they are set for exactly that, high sensitivity but low specificity. So that's going to mean a lot of false alarms. So what's going to happen with that? You're going to get contributing factors to false alarms. Nuisance alarms, false alarms, excessive alarms, that's all going to contribute to your noise. Nuisance alarms, they're often caused by patient movement, when your leads get moved by your patient movement, or they're just placed on incorrectly by your patient or your tech that didn't put them on right, or when your patient moves and they move the leads. False alarms, parameters may be too strict. If you have an AFib patient or a tachycardic patient or a patient that's naturally bradycardic, maybe the alarms do not need to be set for the default, which are usually, for bradycardia, it's 50 or 60. For tachycardia, 120. Maybe you need to increase that. And that's something you need to carefully assess your patient for, of course. But the constant beeping and stuff is not safe for the patient if the patient is stable. Excessive alarms, unnecessary monitoring or devices. Just because we have monitoring doesn't mean the patient necessarily needs the monitoring. The American Heart Association has guidelines as to who should be monitored and for how long. So if you have a patient that really does not meet the criteria for monitoring, you should request your provider to discontinue the monitoring, or ask them why is this patient still monitored. So, because the more patients that are monitored, the more alarms are going to go off, obviously. So, we can cut down on all this noise with this evidence-based practice guidelines. We talked about only monitoring patients with clinical indication, and those recommendations are by the American Heart Association. Okay, proper skin preparation before EKG electrode placement. It is recommended by the Association of Critical Care Nurses, as well as the Joint Commission, to use soap and water before placing the electrodes, not alcohol, because alcohol dries the skin, and then to roughen the skin area a little bit with a washcloth before placing the electrodes. This decreases skin impedance and signal noise. Change the EKG electrodes daily and as needed. This can reduce the false alarms up to 43 to 46%. Customizing alarm parameters to the individual patient or specific population. And that's where we're talking about if you have stable patient that's running a heart rate of over 110 to 120, maybe changing the high heart rate parameter to 130 if he's stable. Again, only changing parameters if you have permission and if you carefully assess the patient. Same with the SpO2 setting and reducing the threshold after assessing the patient. This can reduce false alarms up to 85%. Another big issue is to troubleshoot false alarms when they first occur. Do not ignore the alarm or do not turn it off. Now, what can management do to support nurses? We need the education initially and ongoing. They need to support evidence-based practice in education. Inventory all alarms on the unit and identify their default setting and guidelines of care. Make sure that all alarms are set at where they should be set and they're audible. Establish guidelines for alarm settings in high-risk clinical areas. If you have patients that are on ventilators, you need to make sure those ventilators have a setting that is audible, visible. That needs to be a policy, especially for critical and crisis alarms. Formulate an interdisciplinary team to improve alarm management strategies. It's found that senior leadership and their commitment to patient safety is critical to healthcare organizations. So better quality outcomes have been associated with boards of directors who spend 25% of their time on quality issues. So, but the turn is that they need to realize that it's the system that needs to be changed and not to blame it or change the employees. So, let's review ways we can prevent alarm fatigue. Proper skin preparation. Again, one thing I didn't mention earlier, if your patient has a hairy chest, clip the hair. That's important because you're not going to have them stick if their chest is hairy. Customize alarm parameters for each patient based on their condition. And that's something your team can help with too, and establish some guidelines and policies and give you some direction on as well. Only monitor patients with clinical indication and discuss with your provider if you have a question about that. Change EKG electrodes daily and as needed. I carry a pocket full of EKG electrodes because my patients are constantly pulling them off. And then, delaying SpO2 monitor settings and decreasing the thresholds based on their assessment. And maybe serve on your alarm safety team task force, or definitely if you don't have one, encourage your unit to form one. So, what are crises alarms and what would cause them to occur? We've mentioned them. They're, your life-threatening events where you're going to call a code usually. Systole, VFib, VTAC. These alarms usually are not missed because they're the very loud alarms, and hopefully you all know the sound of a crisis alarm. But it's generally the alarms that precede these that are missed. So it's found that if we don't miss the ones before this, that maybe we can avoid these. No one wants to admit to turning down an alarm or turning one off, but we know it does happen. So we need to just look at our policies and look at our ways that we can improve patient safety with alarm management strategies. In the future, it's predicted that we'll have smart alarms that will, analyze multiple parameters of a patient's condition and can separate the physiological changes from artifact to confirm whether or not it's real or false, and we'll be able to notify the nurse directly and only get real alerts to her, and there won't be any false alarms. Better monitors will be able to customize settings automatically, but that's the future. This is now. We have to rely on what we can do now and make patient safety a priority and implement these measures to prevent alarm fatigue and improve safety standards. So that is my presentation. These are my references, and I hope you all learned something, and thank you very much.